like to just very briefly welcome all of you, all of our head and neck brethren, to our inaugural endocrine section head and neck society webinar. I'll turn the program over to Brendan, and I have worked on this and primarily followed the lead of Nishant Agarwal and Mike Singer, who are our two chairs of our important and very active education committee. They had the wisdom to involve Maisie Shindo and Marika Russell and Babak Givney today to present cases that are considered kind of bread and butter cases, and the great wisdom to involve David Stewart as our inaugural discussant for this webinar. So welcome, and I'll turn over the program to Nishant. We do have a series of webinars that will be occurring over the next few months, over the next 6 months, that will involve some very interesting topics and involve some other international organizations, in fact. So please stay tuned. Betty, wave to everybody there. Betty will be sending out notices for the other webinars. So Nishant, the program is yours.
Thank you, Greg, and welcome again to everyone to the inaugural American Head and Neck Endocrine Section webinar. So I'm Nishant Agarwal from the University of Chicago. I also want to thank the co-organizers, Mike Singer, Brendan Stack, and our fearless leader, Greg Randolph. So thank you, everyone. I'm delighted to be joined today by Dr. Stewart from the University of Cincinnati, who will be our discussant, Dr. Babak Givney from NYU, Marika Russell from UCSF, and Maisie Shindo from OHSU. So welcome, everyone. We have 3 cases today, and we will begin with Dr. Givney on thyroid nodules and the role of molecular testing.
Okay. All right. Can everybody hear me? Well, good evening from New York City. It's a beautiful midsummer day in the city today. It's not very humid, and it's sunny outside. Welcome, everybody. In the interest of time, I'll just get right to it. And please interrupt me when you need. Okay, so the first case is your typical case, a 60-year-old healthy woman with a left thyroid nodule since 2015. And she recently felt that she's having a little bit of dysphagia, no voice changes. She did have a biopsy in 2017 that showed a Hürthle cell Bethesda 3. There was no mutations or gene fusion in the ThyroSeq version that was done at that time, but with version 2. And now she did have a recent ultrasound, as we will go through, and showed mild enlargement, and that's why she came to me. On her history, she does have diabetes, thyroiditis, arthritis, hyperlipidemia. She is actually on low-dose levothyroxine 55, the typo. No radiation exposure, no family history. She does have a palpable left thyroid lobe. It's non-tender, no tracheal deviation. Rectal exam is normal. We do routinely scope people, taking the Lisa Greg, and the scope is normal. So these are the ultrasound images. As you can see, this is the transverse image here. You see a mostly isoechoic nodule. There are some cystic areas. This is the longitudinal. As you can see, there are some vascularity, some cystic areas, no microcalcification. You have beautiful, nice borders. Doesn't seem to be coming out of the thyroid at all. And this is the ultrasound report for you. Basically, right lobe is normal. Left lobe is almost entirely replaced by nodule with a normal equal texture, 5 by 4 by 2.7, smoothly bordered. Routinely, we have TI-RADS scoring at our institution, and the TI-RADS score for this nodule is TI-RADS 3, which is mildly suspicious biopsy of more than 2.5. But there's no significant difference since the last ultrasound in 2016. And then her TSH at this point on 50 of my synthroid is normal. So what would you do? Mr. Break, what would you recommend? Any takers? Who's the discussant?
Yeah, that's me, Babak. So I'll jump in here. So I think there are a couple issues that you bring up. One, a 5-centimeter solid nodule that's indeterminate on biopsy. One wonders if maybe that should have just come out a couple years ago. The fact that the ThyroSeq version 2 had no mutations would suggest that at least 15% of those might still be malignant. I think that test is sort of antiquated a little bit, but it's one that was available at the time. And then perhaps that's why the repeat biopsy was done, because otherwise one would say, well, if it hasn't changed, then why did we biopsy again? Although I may be getting ahead of myself here a little bit.
So let me ask you this, would you biopsy this? The patient comes into your office.
Yeah, the first time, of course, you would biopsy it. I think that a 60-year-old patient with a 5-centimeter solid nodule, you could go directly to the operating room. I don't think anybody would fault you for it, but in today's world, I also think it's very reasonable to do a needle biopsy. Occasionally, you might be surprised that it could be a medullary or something that you didn't expect. It might change your surgery. If the biopsy came back benign, one would feel fairly comfortable watching it. In this case, it was indeterminate. The molecular test was negative, and it was watched. I don't know that I would repeat the needle biopsy. If the patient came to me for a second opinion, I'd probably offer surgical excision if they wanted something done, or continue to monitor it. The repeat biopsy, I think is another option.
Okay. All right. So in the interest of time, I completely agree with what you said. My routine in practice. So at NYU, we have to review all the pathology internally. It's been 2 years old. We have a better ThyroSeq now. So I did the same as you. I actually recommended a repeat FNA. The FNA was done. It basically shows the Hürthle cell arranged in flat sheets. As you can see in a higher magnification, you see all these cluster of Hürthle cells and a little bit of a colloid here. And here you can see again that these are all Hürthle cells with a rich vascular around them. So pathologists, also our cytopathologists, read this as an ITN, indeterminate significance, indeterminate nodule. And at this point now we have ThyroSeq version 3. So we sent it for ThyroSeq and it came back as indeterminate to high, 60% risk of malignancy, surgical consultation. But as you see the fine print, it says no point mutation or gene fusions are found. Multiple chromosomal copy number alterations are identified consistent with clonal neoplasm, associated with 60% probability of cancer. So now we have 60% probability of cancer. I assume at this point you would recommend surgery, but the question is, how much of a surgery would you recommend?
So I think that given a normal right lobe, that I would probably just counsel the patient that we should do a left hemithyroidectomy. I would have them consented for a possible total, with the idea that if there was extrathyroidal extension, suspicious nodes, something that was not identified on the imaging that was present intraoperatively, that would make me convert to a total. I think that there are some people that would argue that you have a 50+% chance of malignancy in a 5-centimeter Hürthle cell neoplasm with or without the molecular testing, and they might upfront go for the total. If it turns out that it had angioinvasion, then you would have made the right decision, but that's not something that we can usually see grossly or on the imaging. So in today's world, where we're trying to lessen our surgical extent, I think the hemithyroidectomy is the obvious choice, with a possible total if there's intraoperative concern for extension outside the thyroid.
I couldn't agree more, and I completely agree with that. The same line of thinking, and we'll discuss a little bit more in the other. Okay. So, and also an excellent point about extrathyroid extension. That's why I do my own ultrasound. I look at it in the office, and before going to the OR, we usually have a very good sense if this tumor is coming out of the thyroid, how it looks, so on and so forth. So my sense was it's probably going to be okay. But I completely agree. Exact same thing. So
so just one point that's coming up on the chat, people are talking about you already discussed this about the repeat biopsy, and that compression by itself is an indication. So do you guys want to talk about that a little bit more? Because I think there's a few comments on the group chat about that. Why even repeat the FNA?
So good question. First of all, this is for us. You do have mild enlargement based on ultrasound, but symptomatically the patient is complaining more. Number one. Number two is this is a patient that was reluctant 2 years ago to undergo thyroidectomy, and I think that's kind of create the rapport. And also, I like to make decisions based on updated data, not the 2-year-old data. And as some of you know, I do a lot of patient safety quality, and I've had the fortune or misfortune of talking to a lot of attorneys for other cases that I have to review. And the one thing that always comes up is, oh, Dr. So-and-so, so this was 2 years ago. You didn't think that you need updated information? And, good luck trying to convince them that no. But in general, I think if we are operating on someone, we should have updated information. That's just my philosophy. But absolutely, there's nothing wrong. And as David said, if you decide that you are doing a diagnostic lobectomy with good information, with newest or ultrasound and the prior biopsy, I'm okay with it. However, before I take a patient to the OR, I want to know exactly what I'm dealing with. That's my philosophy. All right.
And then
we have 2 more cases.
Dave, Claudio brought up a good point. Would you send a frozen section of your lobectomy?
So I basically have stopped doing frozen section long time ago, unless there is something, extracardial extension, something else that really gonna make you sense. But in the lesion itself, we do not routinely send frozen section.
I don't think I would send a frozen in this case either. A solid, possible Hürthle cell neoplasm. I don't think you're going to get much unless you saw something suspicious clinically.
I agree. Okay, so this is I asked our main pathologist to send me these pictures. As you can see, the tumor is completely sectioned throughout, as you can, and these are for your information, the description of the tumor. I routinely sit down with our pathologist and review the case together. That shows basically a tan brown, well encapsulated tumor, most of the lobe, no necrosis, no cystic change, no calcification. This is your low power that shows a intact capsule, and that's the entire area. And you can see the normal thyroid parenchyma. Down here is the adenoma. And as you can see, I'm not a pathologist, but I play one on Zoom every once in a while. This is the Hürthle cell adenoma. You can see the oncocytic cells and granular cytoplasm. Again, there are no necrosis. The mitotic figures are rare. And you see the interaction of the tumor with the normal thyroid. Again, nicely intact capsule. So the final pathology is only a 3.5 centimeter Hürthle cell adenoma, completely excised, negative for carcinoma.
Can I ask a brief question of Dave? Dave, is there a certain size lesion above which you can't adequately accept that the capsule has been definitively ruled out in terms of microinvasion? 6 centimeters, 8 centimeters, something like that, where you say, I get it, you didn't see it, but I don't think a human is able to see it, and you kind of manage the patient as a low-grade de-escalated cancer or not?
It's a very good question, and obviously the bigger the nodule, the more concern that they may have missed angioinvasion or microscopic kind of capsule invasion. But if there was no concern on the pathologist's part, I just accept it for the most part. What I worry about is when they call them atypical adenomas. So they didn't see any definite cancer, but they're kind of concerned about it. And those I code as an uncertain, neoplasm, possible malignant behavior, and those I do follow. So it's not so much just the size of the nodule, although that does play into it. And I have to say, particularly with this new, NIFT-P, that's another factor. If it's a 7 centimeter non-invasive, follicular variant of papillary, am I a little more worried than if it was 2 centimeter? Of course, because it's harder for them to check. But I still feel like, for the most part, I accept it as an adenoma, and I don't feel that's a problem.
Babak and Dave, another couple of questions on pre-op.
Yeah.
One was about pre-operative ultrasound, what the role of that is on cervical node mapping, and then on
So, yeah.
calcitonin measurement.
Sure. So in general, you know, so we have a routine at NYU, and I'm sure the majority of places is we have dedicated people for thyroid ultrasound, and every thyroid ultrasound have to do a few things. Number one is the thyroid structure. It's commenting on the not just the thyroid nodule sizes, but also the consistency. They should have the thyroid, and also they should comment on both central and lateral image. For the interest of time, I didn't put that, but there is always in every single one of our ultrasound that. And if there is not an ultrasound that doesn't have it, that we don't consider it complete. That's number one. Medullary calcitonin is a great question. I routinely don't check calcitonin, but if I go by the ATA guidelines. First step is ultrasound, TSH, and then followed by binding aspiration. Binding aspiration makes me wondering about medullary. Then we would
I'll call you when this is done, okay?
If it's for sure medullary, we also routinely get ret oncogene testing before surgery. We go again by the guideline for ATA.
I'll just add to that. I agree completely on the ultrasound, but with Hürthle cell follicular neoplasm, it's pretty unlikely you're going to see nodal metastases, frankly, but you should certainly look for it. I think when you're looking at a suspicious for malignancy, Bethesda 5 category, I'd worry much more about that and the possibility of a medullary, perhaps. One thing that we didn't really talk much about on the molecular testing, and I think Babak's probably got some more slides on it, but all of them are very, very good for medullary. Now, that's not the cheapest way to make that diagnosis, but if you are getting a molecular test in today's world, it's going to tell you if it's medullary. I tend to order the calcitonin if the pathologist raised the possibility, or clinically that was something I was considering, and use it more selectively. But you're rarely going to be wrong to do it.
Yeah, and I can tell you that I completely agree. And in NYU, we have 4 or 5 cytopathologists that review all the thyroid, and they are constantly having this feedback loop that every single time. So we know exactly where they are and how they interpret things. And the quality control is very strict for us. So we have got to a point that, we trust them a lot, but I think if you are in an environment that you don't know who your colleagues are or you don't have the resources, I think it's very good to be cautious. All right, so we're just gonna open. I brought one paper, and the reason I brought this specific paper is because this is the best paper in genomic dissection of Hürthle cell adenoma. And basically, this is the paragraph that you need to know. If you are worried when you see a Hürthle cell, and I'll tell you, some of my patients freak out the moment they hear it and they Google it and say, oh my God, I'm gonna die. The Hürthle cells that you are worried, and if you're getting genetic testing, the one that show actually mutation. When you don't see any mutation, the risk of having a Hürthle cell neoplasm cancer is really low. And that was one of the reasons that although I see that intermediate to high 60% chance of cancer, I really don't believe it. And for those of you who are interested, Luke Moore is gonna publish a review article in about 2-3 weeks in JAMA Odo, and he has reviewed everything and basically tells you that just because they say it's intermediate to high risk, it really doesn't mean that much. So that's number one. And just gonna open up for a question, and this is my thinking on when I deal with these things. Number one, I'm a head and neck surgeon. I'm old school. It's not cancer until it's cancer. And if you don't have diagnosis of cancer, you should not get a cancer operation. I don't care if this nodule is 5 centimeters, 6 centimeters. If they don't tell me it's cancer, if I don't see anything on my eyes with the ultrasound that shows me any malignant behavior, I still treat it as a diagnostic, and I would do a lobectomy. I have done 6 centimeter lobectomy. And I'm not one of those folks that goes out and just do a total thyroidectomy. Number two is just because ThyroSeq says it's a high risk for cancer, it doesn't mean that it's a high risk cancer. It means that it could be any cancer. And majority of these, when they are even cancer, they are not high risk cancer. So again, not a whole lot of benefit to be heavy handed. And the last thing I always tell my patients, like, well, I can take your thyroid out and do one operation. There's a small possibility that we need to do a second operation. But let me tell you this, there are 100 surgeons in New York City that can take your thyroid out. Last time I checked, nobody can put it back in once it's out. So if it's my sister, I want to have that lobe in there. And if you need to have a second operation, let's have a second operation. So that's all I had. I'm happy to answer your question, David. I would love to hear your commentary.
Guys, we're actually going to move on, if that's okay. Sorry.
Sure.
We've been doing a lot of Q&A during the presentation. So thanks, Babak and Dave, for a very illustrative case and discussion. So for the audience, please mute if you're not speaking. And also, please continue to submit your questions in the group chat. So we'll now move on to Dr. Russell to discuss the extensive surgery for low-risk thyroid cancer.
Okay, great. Good evening, everyone. Babak, I think I need you to unshare your screen.
Yep, I am out. All right. Goodbye, everybody.
Okay. And I'll give you mine in just a second. Are you able to, sorry. Here we go. Okay. And, oh, sorry, I'm going to skip there. Okay, good evening, everyone. So this is the case of a 61-year-old woman, and like the previous case, has an incidentally identified nodule. It was identified on a thyroid ultrasound that was obtained, or a neck ultrasound that was obtained for neck pain. She's otherwise fairly healthy, just some hypoglycemia, hypertension. And she has no family history of thyroid disease or thyroid cancer. She has no personal history of radiation. And her exam is fairly unremarkable. The nodule is not palpable. She has no palpable adenopathy, and her laryngoscopy is normal. I do my own ultrasound as well, and I can see that she has a 1.3 centimeter thyroid nodule. It has some concerning features. It's hypoechoic. There are irregular borders. It's taller than wide. It's got microcalcifications, and I don't see any central neck adenopathy. So she undergoes FNA, and this shows papillary thyroid carcinoma. And so this is a static image of what her nodule looked like. And I'm just going to point out a few things here. I've put these markers here to delineate the borders, but you can see that they're pretty irregular, and it's difficult to distinguish where the borders of this nodule really are. You see the microreflectors here. And the one thing that I notice is that it is posterior within the thyroid. You can see the sort of thyroid capsule here with this hyperechoic line. But in my thinking, this is going to be right up against potentially the nerve. And certainly there's a chance of a positive, microscopically positive margin on a case like this.
And Marika, does it look like there's a smaller one on the other side there on that image?
Yeah, so she's got this tiny small nodule here on the other, in the isthmus, really. I think that's gettable. On the other side, I should mention, she doesn't have any other nodules of interest on the left side. So the first question is, what is your extent of surgery here? And I'll weigh in, I'll let Dave weigh in on that. So,
well, just looking at that single ultrasound picture, I am a little bit concerned that she could have multifocal disease in that contralateral lobe. But if that's really sort of in the isthmus and something that could take the lobectomy with the isthmusectomy, I would definitely talk to her about a hemithyroidectomy, with the idea again that you do a total for gross extrathyroidal extension or nodal metastases that you find at the time of surgery that you maybe somehow missed on the imaging. Small little cystic nodules in the other side, small little isoechoic nodules in the other side. Those don't worry me at all. But when I start to see little calcified, nodules on the other side, then I do start to worry a little bit more about the multifocality possibility. And some of it is what the patient wants, but increasingly I would be counseling the patient to go for less aggressive surgery and a lobectomy. This is a T1 papillary, clinically N0.
Right. And, the role of ipsilateral central neck dissection in a patient like this,
well, if there's suspicious nodes, then I think we all agree that we should take them out in a formal compartment, at least ipsilateral central node dissection. The elective staging central neck is something that I do sometimes consider for patients if we're planning a lobectomy. That's controversial. I don't want to advocate for it. I think you do increase the risk of inadvertent parathyroid removal or damage in doing so. So I think it's a controversy. I don't know where you fall on that side of the fence.
I fall on the side of not doing the prophylactic central neck for a patient like this.
And I think you're in the majority, Sir.
Can I ask, what happens if this patient came to you from an endocrinologist who said this patient has cancer and I was planning a total thyroidectomy, and I counseled the patient in that regard? How would you dovetail your own thoughts with that recommendation?
So that's a great question, and I'm happy to hear what Dave has to say. I was going to get to this a little bit later in the presentation, but I actually contacted my endocrinologist before discussing with this patient what the plan was, because I wanted to be sure that we were on the same page and that we weren't talking about two different operations separately. So I had an idea going in what my endocrinologist was okay with. But I think that's a critical point, right? That you have to be on the same page. And if you get a patient who is being told, two separate plans, it's confusing, it's frustrating, and then they don't trust you. So I think the communication with the endocrinologist up front is key. Now, if you get it after the fact, that's tough. I think then you're in a situation of having a more in-depth conversation with the patient about rationale and, the decisions that the data that goes into those decisions. But in this case, I anticipated that issue, and I asked the endocrinologist up front. So
Marika, sorry, one question. So it came up in the group chat. So what's the role of multifocal disease in your decision of lobectomy versus total?
So that's another great question. So for this patient, I didn't suspect multifocal, although if you look back at that ultrasound, perhaps on that isthmus, there may be. This was a small nodule, and so if you have, I trust the ultrasound, and if it's microscopic disease that is not evident on an ultrasound, I'm more likely to leave it. If it's obvious and I'm, inclined, worried, it depends, it's a conversation. I'm maybe more inclined to offer a total, but I tend to be on the side of leaving it.
And then just one intraoperative question. When would you sacrifice the recurrent laryngeal nerve? How close of a margin will you tolerate?
Well, fortunately, that didn't happen in this case. I'll get to that in a moment, but there's a lot that goes into that decision. It depends on the pathology. It depends on the patient. It depends on their preoperative laryngeal exam. A lot of factors that go into that. I try to anticipate that dilemma ahead of time. That's one of the things that I use my ultrasound for, is to anticipate the need to manage the nerve and tumor on the nerve intraoperatively, so I have an understanding ahead of time what the patient is willing to accept, what they're willing to tolerate, and manage their expectations. So I don't, I'm not sure if I'm answering that question appropriately, but I think it's going to depend on the patient and their disease. So for this patient, she received a right thyroid lobectomy. That's what we went in discussing, planning for. Intraoperatively, she had no clinical evidence of extrathyroidal extension. And interestingly, on her pathology, and the nerve was fine, by the way, came off, no issues. But on the pathology, the tumor was actually smaller than we had anticipated. anticipated. Some of that may have been shrinkage, and some of that may have just been the challenge of seeing that, of determining the borders of that nodule on ultrasound, as I suggested. It was fairly irregular. So it was only measured at 7 millimeters, classic PTC. There are no adverse features apart from a focally positive posterior margin. So kind of what we had anticipated, or what I had anticipated in advance. And so I'd ask for Dr. Stewart, what are your next steps? What are you going to suggest for this patient? Would you observe? Would you offer a completion? If you offer a completion, are you offering radioactive iodine? What are your thoughts?
Yeah, so I don't see worry up there as one of the options, but I don't really like that microscopic positive posterior margin. That's a bad spot to have it. But if grossly you didn't feel like you left any tumor, I would not tell the patient that we need to do a completion and give them radioiodine therapy just because of that. I don't think there's any role for doing a completion without the radioiodine. I mean, if you're the only reason to do the completion is so that you could facilitate the radioactive iodine. And I do, think that microscopic extrathyroidal extension is a very different animal than gross extrathyroidal extension. But I see patients that get referred to me for revision surgery that have recurrences in the strap muscles and down in that TE groove. Sometimes that's the worst spot. So they do sometimes recur. So I'd worry a lot about the patient, but probably not enough to recommend completion in radioactive iodine.
And does the fact that this is now effectively a micro PTC, it's really only 7 millimeters in size, does that shape your thinking at all?
I mean, I think that it makes the argument against completion thyroidectomy and radioactive iodine a stronger argument. But to me, clinically, this was kind of a T1, 1.3 centimeter. Just because the path came back at 0.7, I don't fundamentally change my whole paradigm. I think the patient's going to do well, and if you trust them to follow up, I think that you're probably safe to just watch them. I do tend to put them on thyroid hormone to keep the TSH kind of low normal. I might not actually suppress them, but I wouldn't want them running around with, hypothyroidism or a TSH of 4 or 5 if I was kind of worried about them. That's an easy thing to do, put them on 25 or 50 of the levothyroxine unless their TSH is like 1 anyway. The thyroglobulin won't help you at all here. I do always get it for these hemithyroidectomies. You're reassured when it's low normal. You don't really know what to do if it's high sometimes. You're just hoping it's not really high, I guess. But you're going to have to use ultrasound surveillance.
Right. You mentioned before that you would only do the completion for the radioactive iodine. Do you see any role for the completion so that you can follow thyroglobulin?
I don't think for that microscopic positive margin that thyroglobulin is going to be that sensitive, but you could do that. But again, if you want the thyroglobulin to be sensitive, then you really need to at least do remnant ablation. So to me, they go hand in hand in a case like this. I mean, there may be other cases where I would be very happy to do the completion. Let's say the issue of multifocality came up. So if the other lobe is sonographically normal, I don't really worry about microscopic multifocality so much. But if the other side has little things that sort of look like little papillary carcinomas, I do want to kind of do that completion. And then if there was no extrathyroidal extension, no nodes involved, I don't necessarily feel like I have to give radioactive iodine just for that. But the rationale to me here, if you did the completion, would be to give the radioactive iodine to try to kill whatever microscopic papillary could be left there in that thyroid bed or, right on the trachea or wherever it was.
So
can I ask a question? Is there a number below which, after lobectomy of TG, you're comfortable, and a number above which you become uncomfortable?
Well, I know that I asked Mike Tuttle, who I consider the, endocrine guru of thyroid cancer, to at least tell us, what we should do here. And his paper came out and said if it's 30 or less, they're fine. And if it's more than that, then it's not quite normal. But that was just half of their reference range. I think it went from 0 to 60. So it sort of makes you feel good most of the time, but what happens if it's 50? Are you going to tell them they have to have a completion thyroidectomy? Probably not. So I do tend to get it, and most of the time, thankfully, it's kind of low normal and we're okay. But it can be elevated in Hashimoto's for other benign nodules. So I think that one of the things we're going to have to accept as surgeons is if we're doing hemithyroidectomies for thyroid cancer, we're going to have to use our ultrasound to follow the patients. We're not going to be able to use the thyroglobulin.
So a couple of comments on the group chat. I think, Marika, you have one more slide. So I think these points keep coming up is the status of the nerve. So I think if you have a well-differentiated thyroid cancer and a functional nerve, the goal is always to try to preserve it. I don't know, Marika and David, comment on that. Another question was how accurate is ultrasound preoperatively in determining the true size of the nodule or cancer? As you, in this case, there was a significant difference.
Right, and I think some of that is probably due to the challenges of defining those borders on this particular nodule. I've looked back at that image a few times, and each time I look at it, I think I can outline it differently, and that's just reflective of the ultrasonographic features of PTC. But in general, I do find that there's some shift. Usually, it's smaller when it's removed than what I measure. Again, when you're measuring on ultrasound, it's somewhat arbitrary. It's imprecise. I may take a measurement on a depth of field that is somewhat different than somebody else. So I'm going to be off by a couple millimeters, perhaps. So I don't use it as a precise feature in that sense.
Yeah, and I agree. I think that the ultrasound probably is the accurate in vivo sort of measurement, although in this case there were kind of indistinct borders, but the path, when it's been in formaldehyde, it tends to shrink a little bit. And I kind of like that when it goes from the, T1B to the T1A or the T2 to the T1. I mean, that's always kind of good, especially when it goes from the T3 to the T2.
Right.
And so I think that's a common thing. Regarding the nerve, I would say that where I would get more aggressive with the management of nerve involvement is in a revision case. So they've basically failed the initial therapy and now they've recurred structurally. And so I agree with you completely. With a functioning nerve, I'm going to do everything I can to peel the tumor off the nerve. But if they've recurred structurally, even if that nerve is working, if that nerve is clearly involved grossly with tumor, I am much more likely to sacrifice it. But initial surgery, I would always try to preserve a functioning nerve.
Yeah, and I agree with that. So we elected to observe this patient. You'll be happy to know. And so we've already hit on a number of these discussion points, but in the discussion of extent of thyroidectomy, the role of multidisciplinary decision making, the conversation with the endocrinologist, the timing of that conversation, and then what you ask of the patient. What is their role in determining the extent of surgery, and how do you provide informed consent on that? We're not really touching much today on this. It's fairly loaded, but the point of microscopically positive margins in low risk disease, we've kind of hit on this. There's one paper that I wanted to review. This was actually out of my institution at UCSF, out of the endocrine surgery group. And this was a study reviewing T1, T2 cancers with positive margins. So this was 684 cases. The study cohort was ranged the years 2000 to 2010. So these were all patients who were treated prior to the current iteration of the ATA guidelines. They all received a total thyroidectomy, but 78 of them, so 11%, had microscopically positive margins. Amongst those who had positive margins, 60% received radioactive iodine, 51% not in the 51% did in the negative margin group. So really no difference. The overall recurrence rate was fairly low. It was mostly nodal recurrences, only one local recurrence that was over a median follow-up of 46 months. And as we've been discussing or hinting at today, the predictors of recurrence here were contralateral multifocality and a positive nodal status. But by itself, a microscopically positive margin was not an independent predictor of recurrence for these low-risk cancers. So some supports what we've discussed today.
Just one last question before we move to the next case is how often would you monitor this patient?
How often would I monitor this patient? I think I'll probably, if this is low risk disease, it's slow growing. I'm not going to see any structural change on an ultrasound for several months at least. So, I might see the patient. I find ultrasound in the immediate perioperative period challenging to interpret. I might wait 6 months before I perform my first ultrasound and probably wait another 6 months after that. I don't know that we have good data to support the interval or guide the interval for those evaluations. But given that this is fairly, I expect this to be low risk, slow growing disease. I'm not terribly concerned at this point that she needs very aggressive surveillance. I don't know if you'd agree with that.
Yeah, I would agree. I tend to do a TSH and a thyroglobulin at 1 month and not do an ultrasound. And then at 6 months, I'd repeat the TSH and the thyroglobulin and I would do an ultrasound. And then if I saw something suspicious, I'd probably do the ultrasound in 6 more months. But the vast majority of the time, I would just shift it to annual follow-up thereafter. And I tend to stick with the annual ultrasounds, although as we get farther out with patients, especially if they're being followed by the endocrinologist with the thyroglobulin and they had a total, and I might move the ultrasound out to every couple of years.
Yeah, I agree with that. Yeah.
Thank you, Marika and Dave, for another very insightful discussion. So our final presenter is Dr. Shindo, who will present a case on primary hyperparathyroidism without localization on preoperative imaging.
Mute myself. Can you all hear me?
Yes.
Great. Okay, let me share my screen here. Let's see. This is from, hang on here, let me just see here. Is this the one from that I sent you guys?
Yeah,
No, this is the one from my desk. Okay, hold on. No, I just want to make sure that this was.
It's a different slide. It's actually a different slide deck.
Yeah. I just added 2 more slides today. Okay, perfect. So this is a parathyroid case. All right. It's a 32-year-old female who was referred to me for parathyroidectomy. She's been hypercalcemic for the last 3 years. No history of nephrolithiasis, musculoskeletal pain, or constipation or depression. So really no symptoms. She does have some fatigue, no history of fractures, and the reason she was sent was just because of her age. Here are her labs. As you can see, calcium is elevated. FOS is pretty normal. Ionized calcium is elevated. Normal kidney function, PTH is 105. And the 24-hour urine calcium is quite high. It's 531. So the imaging studies were actually ordered by the outside surgeon. She's had 2 sesame baby scans a year apart, which were non-localizing. Ultrasound was read as normal, and then a triple phase CT scan was done, and it was read as no parathyroid adenoma identified. So I think that maybe I'll just sort of move on because in the interest of time. So I think some of the considerations in somebody like this with non-localizing studies would be hyperplasia, would be top of my list. And you need to start thinking about multiple endocrine neoplasia syndrome, where they often present with multiglandular disease or hyperplasia. And there's some very other rare things that we have picked up and have learned from, which is these patients with significant hypercalciuria, like in the range of 500 or higher, they tend to have often non-localization studies. And it's a little unclear as to whether or not they've had chronic long-term hypercalciuria with mild hyperplasia, and then one of the glands perhaps over time becomes a little bit autonomous. and then they start presenting with hypercalcemia. So these are some of the things to think about as before you start, jumping into surgery. So because of that, you also want to get then a very good family history, which is important. And we found out that the mother had parathyroidectomy, but she denies any family history of thyroid cancer, pituitary tumor, adrenal tumor. So these are the standard questions that, I always ask every patient who walks in with primary hyperparathyroidism. So, once we get this history, then as deemed appropriate, we would work them up for rule out MAN. So I might order a gastrin level or FSH, LH level to rule out MAN1, and potentially even calcitonin level. So Dave, at this point, there's nothing else that has shown up, in the history other than the mom who had parathyroidectomy, which was, there was no history of MAN. It was a single gland parathyroidectomy, and reportedly the mom's been cured. So this is probably familial primary hyperparathyroidism.
Yeah, I would still worry a little bit about MEN1, but not enough to start ordering genetic testing. I think I would just keep that in the back of my mind. I, of course, would want to do my own ultrasound to be sure that they didn't miss a small adenoma that I would be able to see. But I think the patient's probably going to need a 4-gland exploration, and unless it's clearly a single adenoma, is going to need a subtotal parathyroidectomy.
Okay, yeah. So, and that's how I approach these patients. One of the things that I'll often do is actually review the imaging studies myself, especially like the CAT scans. It depends on these are outside imaging studies. So. I think one of the pearls that I can probably pass on is look at your own imaging studies, because sometimes you pick up things that the outside radiologist may not appreciate. Actually, I need to minimize this a little bit here. Okay, so I looked at her CT scan, and I'm just going to kind of point out the one thing that I kind of picked up that sort of gave me a hint. So if you look at, the classic triple phase is a non-contrast, which is this, and then the arterial phase, and then the venous delay phase. So if you look at the arterial phase, the one thing that caught my eye, and this is very subtle, is this is the left superior pole thyroid. You can see there's normal slightly higher attenuation of the normal thyroid. Then I looked at this, I didn't think much of this. Then I looked at the arterial phase and I thought, oh, this is the same cut. And then you have this sort of like brightness behind it. And so, I had to go back and look at it a few times. And then I looked at the corresponding venous phase, and you can see that this is, less attenuated than the arterial phase. So I thought, wow, okay, maybe there is potentially something there. Because if you see something on the imaging study, at least you have a starting point. That you can start, and not necessarily just sort of arbitrarily flip a coin and pick a side. So then I did my own in-office ultrasound, as Dave actually pointed out. So I did her in the operating room, because once they're asleep under general anesthesia, you can actually sort of press a lot harder and look in the deeper spaces. So I want to just point something out to you. And I had to go through this twice before I picked this one up, because I was focusing on this to see if this was real. So if you just kind of like look at this area, here's thyroid, and then you saw this little hypoechoic thing that just went by. So I'm going to see if I can slow this down and show you this. Right there. I don't know if you guys saw that or not. So that was, at least, there just isn't anything hypoechoic there to explain this finding. So I thought at least we would start on that side. And sure enough, we found an enlarged parathyroid gland that was, that was the culprit. And I went ahead, because she's young and risk of multiglandular disease, I went ahead and looked at the lower inferior parathyroid gland on the same side as I was waiting for the intra-PTH. We identified a normal one, and the PTH actually completely normalized and dropped 70%. So we were done. And I think this is one of the pearls that I can pass on is that look at the imaging studies yourself, and if you have the capability and the experience, do your own ultrasound. And some of the areas that are often missed are like retroesophageal, paraesophageal adenomas in ultrasound. And the other thing is like the really low-lying parathyroid adenomas, and even the radiologist can potentially miss some of these. So here's another one. This is a different patient, but just to give you an example, his arterial phase, venous phase, and this was actually missed by radiology, outside radiology, and we saw that, so we went after that. But that's just a couple of comments about the multi-phase CT. So there was a nice study that came out that looked at the different patterns of enhancement of the parathyroid adenoma. And so basically we all know that in the non-contrast phase, as I showed you on the patient, the parathyroid has a lower attenuation than the adjacent thyroid. But they found 3 different patterns of enhancement in the parathyroid. And the most common one was 57% of them had an arterial phase that was similar. The attenuation was similar to the thyroid. So here it is. This is the arterial phase. This is an example of it. Here's the thyroid. And you can see the enhancement is somewhat similar to the thyroid. But then in the delay phase, it's actually lower than the thyroid. So you can see this is the corresponding cuts. Here is the thyroid. And this is next to the esophagus. And you can see how much lower in attenuation that is. So this is fairly classic. And it would be fairly straightforward in making the diagnosis. But you can also have this 22% of these they found had this type C pattern where the arterial phase is again similar to the thyroid, but it just doesn't wash out like this. And so the venous phase, the thyroid and the parathyroid would look very similar in attenuation. So those are, they may be missed by the radiologist. So I think, in a patient with non-localizing studies, think about MEN, familial type, CESR mutation that causes hypercalciuria, and then look at the imaging studies yourself, because you might pick something up and redo your own ultrasound. And these are some really good, I think, references that pertain to this topic. The reference that I was just talking about is this one in a journal of radiology by BAHL. I think that's all I had to say. Dave?
One question that came up in the group chat is when do you perform a F-choline PET CT with negative sesame?
So I think the Sesame scan we used to obviously routinely use, but I've used this so few times. And the reason for that is that ultrasound for me has replaced the Sesame scan. Because if you can do a good parathyroid ultrasonography, you're pretty much going to pick up most of these parathyroid adenomas. And I doubt that the Sesame scan is going to pick something else up that a good, parathyroid ultrasound will miss. So our combo is basically a triple phase CT and ultrasound. And the only time when I might do a Sesame is in somebody who has pretty significant renal insufficiency, where I don't want to tip them over and put them in kidney failure. And then I might do a Sesame scan. I don't do the PET scan. I just think that these two modalities with the CT and the ultrasound is just such high yield that I'm not sure that that's going to add a whole lot more. And then we just prepare for foregland expiration with possible subtotal parathyroidectomy.
Hey,
Dave, any
Dave.
thoughts?
Dave, this is Brendan Stack. Can I just chime in something on the PET scan? I agree with you, Maisie, completely. I think the person that asked the question about the PET scan is one of our international participants, and really using F18 choline or 11-choline would be off-label uses in the United States, although they may be potentially helpful, probably in a non-localizing reoperative case.
Right. So yeah, reoperative cases are a little bit different. And, you know, you can, I mean, there are different options for that, but even with the reoperative case, you know, we would probably start with the parathyroid CT and an ultrasound to begin with, and then consider, you know, other modalities such as interoperative image, you know, interoperative radio-guided parathyroid surgery, for example, in a reoperative case.
Dave, you have any comments?
Yeah, I think that Maisie's point about looking at the images yourself is really critical. I know Brendan published a paper more than a decade ago showing that the surgeons are much more sensitive than the radiologists. We may not be as specific, but rather than flipping a coin, we're going to want to look really hard at it ourselves. And, you know, as somebody that does my own ultrasound, I agree completely that the vast majority of small parathyroid adenomas you can find with the ultrasound, it's probably the most sensitive tool that we have. There's some locations where it's clearly limited, and then whether you like the multi-phase CT or the Sestamibi SPECT CT, you know, that may be based on what your radiologists are most experienced with. I think these quasi to non-localized parathyroid cases, especially where there's a family history, those are pretty typical. I don't think you would have been wrong to have done the bilateral exploration here. But if you did do it, at least in my hands, I would probably say, well, that could have been a small little adenoma left superior that Maisie found. But now that I've explored both sides, I don't want to be wrong. So I'm taking 2 more glands and I'm only leaving 1, and I'm going to mark it well. I might not do the 3.5 in that case. Whereas the strategy that Maisie employed to go to the suspected small adenoma and then, you know, wait on the PTH, and if it doesn't go down, then you're doing a bilateral exploration, and if it does, great, is another great way to go. You've not burned any bridges. And checking the ipsilateral gland as an inpatient surgeon, that's what I would often do too, because I can find that second gland pretty fast if it's hyperplastic, and then I know I need to take out more glands and go to the other side. I probably wouldn't take it out right away. I'd just jump to the other side. But if you can't find it, or you find a normal one, don't go to the other side and wait for the PTH is a very reasonable approach. The only reason I would say you'd be okay to do the bilateral is just the family history, but then don't undertreat them if you do the bilateral exploration.
Right, and I think that you know, in doing 4-gland exploration, one of the important things to remember is you don't really want to start taking out the glands as you see them, as you start identifying them. I think if you're really committed to a 4-gland exploration, and so the first gland that I did find looked like an adenoma, which is why I was comfortable taking it out. But if it doesn't, just go find the next one, go find the next one, find all 4, and then decide what you're going to take out and then what you're going to leave behind, because what you're going to leave behind needs to be highly vascularized and viable looking. And so if you remove, you know, the first one that you saw, it may not end up being the one that's the most viable one, and then you're screwed. So that's one of the probably very important points to remember when you're kind of committing yourself to a 4-gland exploration. And with this woman, I did, you know, tell her, I said, look, if this did turn out to be the culprit, and we do normalize your PTH, you still have a reasonable chance of recurrence 5-10 years down the road, but I haven't touched your other side. And I did tell her that I was going to go ahead and identify the normal one to make sure it was normal, so that hopefully people didn't have to go back to that same side.
All right, everyone. Well, thank you, Maisie and Dave. We're at 7 o'clock Central Time. So I want to thank Mike Singer, Brendan, Greg, our discussant, David Stewart, Babak, Marika, and Maisie for participating in this webinar, and all the audience members. So please join us for our next webinar on August 19th, led by Mike Singer. We're going to talk about reoperative endocrine surgical cases. And in December, we're planning a pretty special transatlantic webinar with the British Association of Endocrine and Thyroid Surgeons. So thank you, everyone, for participating, and see you again soon.
Thanks, Nishant.
Thanks for putting this together.
Thank you, everyone. Good night.